Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we hear from two experts answering questions about how you can become a vaccine expert for your patients. We're joined by Dr. Robert Hopkins Jr. from University of Arkansas for Medical Sciences College of Medicine, and by Dr. Litjen from the Chief Policy and Partnership Office at Immunize.org. He's also the chair of the National Adult Influenza Immunization Summit and co-chair of the Global Influenza Initiative, St. Paul, Minnesota. For more information on Dr. Hopkins and Dr. Tan, along with a link to the larger educational program, visit the show notes for this episode. Now let's get started.
I am LJ Tan with Immunize.org, and I am obviously delighted to be here with Dr. Bob Hopkins. I think we look forward to answering your questions as we get to the end of this program. But before we do that, a couple of quick didactic sessions, I would like to say, but I'll try to keep it as entertaining as possible. So becoming a vaccine expert, I think many of you already are. I think this is just a refresher to help us kind of remind us that in the current environment, that there is a lot of evidence for the use of vaccines, but also for the safety of vaccines. So I'm just going to start by helping us recall that, vaccines saves lives, but, we don't do a great job of using all of them. And as a result, we still have vaccine preventable diseases persisting in this country. And these are just some numbers to draw home that fact. I mean, I think we want to remind ourselves that there are deaths because of vaccine preventable diseases, and these are adult deaths. And again, I want to point out that this is mortality, right? So, depending on the season, you get influenza mortality as averaging about 28,000 a year, pneumococcal pneumonia, and that's just these two vaccine preventable diseases. We can add hepatitis B, we can add HPV, we can add a lot of other adult vaccine preventable diseases here that will increase that mortality burden. The hospitalizations obviously remain a challenge. This is our morbidity impact. Obviously, we have influenza and pneumococcal hospitalization annual rates here, but I want to remind us that hospitalizations also extend to COVID-19 disease. It also extends to RSV and many other vaccine preventable diseases that we do not do a good job of vaccinating against. And so those hospitalization rates are far higher than they need to be. And all that being said, the other thing I want to remind us, and I'll come back to this, is that in addition to the morbidity of hospitalizations and medically attended visits, we have quality of life issues that we would probably want to talk a little bit about. When you get a vaccine preventable disease and you have not been vaccinated against that, you will have more severe illness that could lead to quality of life impact. And I think that's something we want to think about. And so if morbidity is not an issue, if it does not convince you, if mortality does not convince you, the last box on this, cost burden, hopefully will help push this over. Recognizing that no vaccine is 100% effective, if all we did was vaccinate our adult population a little bit better, this economic burden would be dramatically reduced for influenza and pneumococcal disease, both vaccine preventable disease. So morbidity, mortality, cost, great reasons why we need to be protecting against vaccine preventable diseases. And then the final thing, obviously, we all know it reduces transmission of communicable diseases. It reduces the odds of some people catching hepatitis B, which leads to chronic hepatitis B, HPV, two things I've already mentioned earlier. And then additionally, it also we have to remind ourselves, and this is also part of that whole idea about quality of life, that vaccine preventable diseases can increase the risk of non-communicable chronic illness as well. And exacerbate those existing chronic conditions. So something we want to kind of keep in mind with the benefits of vaccines. So moving on, this is the whole idea of also kind of reminding all of us that vaccine effectiveness is not just measured by the primary infection that it prevents. So it's not just about preventing a single case or cases of influenza or pneumococcal disease or RSV or COVID-19 and so on and so forth. We want to remind ourselves that beyond protecting against disease, vaccination also reduces a lot of other complications from the disease, like medically attended disease. So again, not just about reducing primary infection, it is about reducing some of these complications, serious illnesses, hospitalizations, and of course, indeed, deaths from these illnesses. And then a little refresher to remind us that vaccines in the United States are probably the safest, we have probably the safest, most effective vaccine surveillance system in the world. And I want to remind us how we go through the process of getting to our final vaccine recommendations for use of a vaccine. So just to note that before a vaccine even enters clinical trials, there is a lot of basic research to support the use of that vaccine, which includes things like, of course, using basic research to discover vaccine-suitable antigens, and of course, preclinical studies in animals to make sure, of course, that the vaccine is safe and effective in animals. If it passes the muster in these basic research, it then goes into clinical trials, and reminding us that vaccine clinical trials are rigorous, evidence-based, randomized control. Okay. So just to remind all of us that there are three phases. Phase one first looked, of course, at safety, phase and a little bit of immunogenicity as well, and dosing. And then phase two goes further into dosing, safety, and immunogenicity studies. And when it goes through out of those, and we have what we establish as a safe immunogenic dose, that is then advanced into clinical trials, which is the large base trials that you all hear about that eventually establishes licensure, right? So as part of that licensure process, a biologics license application, we call it BLA, submitted to the FDA. The FDA goes through its evidence-based review process. There's a committee that advises the FDA to do that. It's called VRPAC. And then from that, we get FDA approval. Following licensure of the vaccine, that vaccine or authorization, as the case may be, that vaccine goes into the Advisory Committee on Immunization Practices review, again, evidence-based, science-based review process that then leads to an ACIP recommendation. That ACIP recommendation is then signed off by the CDC director, which then brings the vaccine into widespread use in our population. And then that doesn't end everything. It goes into post-approval monitoring and research. And part of that is also our vaccine safety surveillance. And as I said earlier, I think our vaccine safety in the United States remains one of the best in the world. We have a passive surveillance system called VAERS, which is the Vaccine Adverse Event Reporting System. Just a reminder, this is a passive system. It's like the canary in the coal mine situation, right? So it looks for signals. It cannot validate if that signal actually was caused by the vaccine, right? So it looks for those signals. Once we get a signal, it then goes into more active systems that can validate causality. So for example, like the vaccine safety data link, right? And for CISA, those are things where we actually try to validate causality. VAERS cannot do that. It is passive. I also want to mention that the FDA also has a surveillance system. It's called the Sentinel Best system. This is part of the post-marketing approval process. It allows the FDA to monitor biologics, of which vaccines are one of them, for additional data to ensure safety and effectiveness. So again, so many processes are in place here to help ensure safety and effectiveness of our vaccines after licensure and after recommendation. And then finally, just to kind of rah us on, right? Ha, rah, rah, rah. The status quo in vaccination is clear. Vaccines are safe. They are effective, right? They are our social norm. More people accept and receive vaccinations than actually decline vaccination. So we need to continue to emphasize that social norm and that most patients and parents do vaccinate. When this majority is supported, and they have to be supported, they will and can become powerful advocates in our communities for vaccines. And so I think this is how I want to leave us all and turn this over to Dr. Hopkins so that he can talk to us a little bit about the clinical relevance of vaccines. Thank you so much, Bob. And thanks everybody for listening. Looking forward to your questions.
Well, good afternoon. Thank you, LJ, for the setup. It is always a challenging process to take over a talk after LJ Tan. He's a passionate advocate for things. So as we think about the process in our day-to-day care, in our offices, in our hospitals and others, we need to really think about how do we take this and move forward? Well, the first piece is we need to make sure that we understand our current clinical context in our day-to-day life. In different areas, in different communities, you're going to have different specific concerns that are common around vaccines or around other health issues in your community. Knowing that local context is really important to starting your process of talking to your patients about vaccination. Remember that your message matters and how you present it to the patient. If you have a narrative, if you have a story, people understand and take in stories far better than they do facts or numbers. And communicating the risk of not vaccinating, to me, is far more important than communicating the risks of vaccinating. There are lots of methods we have that are evidence-based that have been validated to support us as healthcare professionals in engaging in conversation with patients and parents about vaccination when they raise concerns. And I think it's important that we collect and share those best practices. So, first and foremost, we as healthcare professionals remain the number one reason why most adult patients get vaccinated. And this has been reflected similarly in the pediatric side of things as well. But we need to provide clear, concise, and consistent recommendations about vaccination. If we're waffling, if we're offering vaccines like you might offer to sell somebody a hamburger or a cheeseburger, you're not going to get there. There's actually evidence that shows if you offer vaccines, you actually reduce the importance as the patient hears it, and you reduce the likelihood of somebody getting vaccinated. So a clear, concise, consistent recommendation. And if you see your patient raise their eyebrows, if they knot their brow, if they raise a question, if they raise a finger, if they look away from you, anything that gives you a clue that they have questions, concerns, or doubts, then you need to pivot. You need to pivot to either a motivational interviewing strategy or another evidence-based strategy to approach your conversation with that patient to get them to the goal of getting vaccinated. And rule, aims, and case are three of those evidence-based strategies, and we're going to talk a bit about rule here in just a moment. Rule are a set of motivational interviewing principles that we can use very simply in our practicing world. And motivational interviewing, I know many of you say, oh no, it's a 30-minute process. No, we're talking about 5 to 8 minutes maximum. First piece is the most important. We need to resist our what we call the writing reflex. What? You say what? No. We resist our getting our back up, and we need to focus in on the patient and make sure they recognize that we recognize them as humans, recognize they have autonomy, and recognize that we are working together to be committed to providing health care for their patient. So resist that writing reflex and that we're committed to providing them health care. Second, we need to ask questions to understand motivations and elicit the values and concerns of that patient or family member in front of you. Not to correct them, but to understand them. Third is listen, not to respond, but so that we can understand where they're coming from. So you ask the questions and then you listen to the response. And then finally, you want to empower patients by guiding them through a process of thinking aloud and deciding whether to change. For example, I might say to LJ, you want to go spend some time with your son. Isn't it important to you that you not be sick with influenza or develop pneumonia and end up in the hospital this winter? Let's get that vaccine today to help you be able to do what you want to do. That's the kind of empowerment that we're talking. As we talk about alleviating patient concerns about vaccination, a couple of critical points that we need to remember, actually 2 or 3. First is that facts alone rarely change people's behaviors. Many more of our decisions are based on emotions than they are in fact. It's important that we not repeat myths, even in the context of refuting them. To repeat a myth actually solidifies that hesitancy in many people's minds. We really need to resist our tendency to scold, to chide, or to use fear tactics. We want to speak to individual and family interests and goals. Context matters. If this is a new grandparent, we want to think about what can we do to facilitate them spending time with their grandchild. If this is an older adult that loves to go out and spend time on the trout stream like I do, you need to think about what can we do to help encourage them to do those things in a healthy and safe manner. Again, stories much better than science or data. We need to remember the concept of cultural humility. While I may know this patient well and have taken care of them for years and years or even decades, that doesn't mean that I know all of the context around how they make decisions or who they have telling them that this may be a bad thing for them to do as opposed to a good thing. So have the humility to ask those questions and to understand. And we need to remember to allow patients to think, and that we may even need to have a follow-up conversation rather than getting them to that goal of vaccination today. So it's not a loss to not get somebody vaccinated today. As long as we remember that we come back to that conversation again next time, we document that we've had the conversation. Unfortunately, there's not a billing code for this documentation for adults. There is in kids. LG and I'd love to see it happen for adults. We're working on it, but document it so we remember to come back to it next time. Having conversations over time. This is a long game, not a short game. So as we think about the totality of improving our practices, There are also a number of other tools through CCO about this whole process. We've got to remember to know our facts about the vaccines that we're talking about, know our facts about the safety and effectiveness. We need to remember to make a strong presumptive recommendation. Don't ask, recommend. Ideally, I want you to give a reason why. I want you to get this vaccine so that you can enjoy your fall and your winter on the ski slopes, or you can enjoy your fall and winter with your new kids or grandkids or other things. A why that makes a difference to your patient. The closer your why is to that patient's motivations, the more likely they're going to accept the vaccine. And if you're unsuccessful, shift strategy. Think about, you've got heart failure. We know that influenza increases the risk for heart failure admissions. So we really want to make sure that you're protected against influenza to reduce your likelihood of being in the hospital with heart failure. So diagnosis-based or motivational interviewing are ways to get you there. We need to acknowledge when patients have legitimate concerns. We know that a number of our vaccines are very reactogenic. They commonly cause fever, sore arm, those kind of things. Acknowledge those concerns, but we also need to recognize the benefits. And we need to, again, as I said earlier, recognize the long game. It's really important that we make sure that our primary care and our specialty healthcare professionals are on the same page. If my recommendation and the cardiologist's recommendation are the same for vaccination, we're much more likely to get that patient vaccinated. Many of our patients feel a real alignment with their specialist they've had for a long period of time. So making sure that alignment is there. And final point is try to eliminate barriers. I try to vaccinate at every visit. I was in clinic yesterday morning, and my medical assistant at the end of clinic always says, "You wear me out." Because at the end of every clinic, I've vaccinated almost everybody you've seen. Well, that's the goal. I said, "Now, you're up to date, right?" And she said, "Of course I am." So, eliminate those barriers. Let's make it easy for our patients because that helps simplify the process. If I have to send somebody somewhere else to get the vaccine, that's going to reduce uptake significantly. So with that, we've set you up with the tee up. We want to answer your questions. LJ and I both love to talk through all of these concepts. But, while we're waiting on some questions to come in, LJ, could you tell us just a minute about the difference between ACIP making a recommendation and how that becomes public health policy? Because that's something that's a really common question now.
Yeah. So just to help everyone understand, the advisory committee on immunization practices is something that advises the CDC directive for vaccine recommendations that's done in population health. So what it does is it looks at evidence, a preponderance of peer-reviewed evidence that supports the use of the vaccines in specific populations, and then it makes a recommendation based on its review of that population. There is an evidence to recommendation framework that the ACIP uses that covers multiple domains. I'm not going to go through all of them, but it includes the public health impact of the vaccine preventable disease itself, the effectiveness, obviously, of the vaccine as well, safety, acceptability by healthcare providers and the public, so on and so forth, and other things as well. But all that then factors into a recommendation that the ACIP then comes out with. And that recommendation currently can be a routine recommendation for a specific target population, a routine recommendation for a general, large age-based recommendation population, or it can also be what we call a shared clinical decision-making, where the vaccine is definitely safe, it's effective, it's recommended for use, but through a discussion process with the clinician that's in front of the patient. And those recommendations are incredibly evidence-based. They come out following licensure by the vaccine of the FDA. The FDA has to license the vaccine, or authorize it. Then the ACIP looks at everything and makes a recommendation based on that evidence to framework recommendation framework. So I just want to reassure everybody, that our existing ACIP recommendations are founded in the best science, and in fact, they are the evidence-based schedule. When you see that adult vaccine schedule in front of you, it is the evidence-based schedule that we're talking about.
And the CDC director has to sign off on those recommendations for it to become CDC or public health policy, and for our insurers to pay for those vaccines, or be required to pay for those vaccines.
Absolutely. That is incredibly important. And actually, Bob, while we're talking about that and still waiting for questions here, I want to, let's take that a little bit further, right? So we know recently there's been some decision process that's been made where for COVID-19 vaccination of pregnant people, the recommendation for pregnant persons have now been moved towards a no recommendation. And indeed, if you go to the risk-based adult schedule, the box for pregnant persons is now basically blank, which means no recommendation. Bob, what do you think about that? What's your advice here for folks who are looking to vaccinate pregnant persons here?
Well, I think a couple of points are important. Number one, I think it's really disturbing to me that we have a process that's been used that's not the ordinary process. It's not an evidence-based process reviewed and subject to discussion by numerous experts in all of these different areas, from public health through the science of vaccinology to clinical practice. So that's piece number one. Piece number two is the evidence is really pretty well settled. Not pretty well. The evidence is settled that COVID-19 vaccination in pregnancy reduces the risk for hospitalization and death in the pregnant woman. It reduces the risk for hospitalization of infants out to a minimum of 3, if not 6 months after birth, at an age when infants cannot be vaccinated against COVID-19. So the science is that COVID-19 vaccines are safe and effective in pregnant women, and they should be used. It's really dismaying to me that we've had a process used that doesn't recognize the science. What I'm doing is I'm recognizing that we have evidence behind this, and I'm recommending that pregnant women under my care get vaccinated because I want them and their infants protected. This dividing the messaging out there doesn't do anything but make things more difficult for us.
Thank you, Bob. Really appreciate hearing that. I think there's a question out there, Bob. Do you want me to start off with that? There's a question about the best practice for working with patients for fear of needles, and then maybe I'll tee it off for you, Bob, as we go. Sure. And the reason I want to do this is, Immunization.org actually has recognized the fact that up to 1 in 5 adult patients has a fear of needles, and that actually is the fundamental motivation for declining a vaccine. Although they may say something else, it turns out it is actually fundamentally a fear of needles. So we actually have provided a couple of tools in our website at Immunize.org where we talk about how do you distract or how do you alleviate the fear of needles in adults. And there are multiple tools that you can use to alleviate that fear, including things like you can put things that actually desensitize the site, either because of the fact that they're little patches, they're plastic patches that have little plastic globules on it. So it actually desensitizes the site. So when the needle goes in, you don't feel it. So there are a lot of interventions, physical interventions you can use to distract from the site of the pain. And that actually helps a lot of adults. And then obviously, I think one of the most important things is to acknowledge the fact that there is a discomfort to receiving a vaccine. I think as Bob said earlier, to chide or to kind of, belittle and say, hey, it doesn't hurt at all. That doesn't help. I think you need to acknowledge that reflection of fear, support it, and then use these interventions to prevent that. Bob, I tee it over to you.
The other piece that I think is important is ask the patient. If they have a fear of needles or that kind of thing, ask them what's worked well for them before. I have at least one patient I have this conversation every fall about. And she says, can't we use a smaller needle than the traditional needle we use for vaccines? Yes. As long as it's long enough to get that influenza vaccine into the muscle, we can certainly use a smaller needle. Some people want to see what you're doing. I have a number of patients that have needle fears that say, no, I don't want you to see it. Just come up from behind me, give me the vaccine, and I'll be okay. I have had some that say, hold my hand. I want somebody to hold my hand. I'd use distraction techniques. There are lots of things we can do to help in those situations. I see another question here asking about motivational interviewing. And is it effective in working with patients who have incorrect but fixed belief about vaccines? Some patients seem to feel their fixed belief is more important than learning about evidence-based information. Well, motivational interviewing can be helpful in those patients, but I would expect in that type of patient, this is going to be a much longer process than just a 1 or 2 time conversation. And again, that's a patient that I say, I understand your concerns. Let's talk about what's important to you right now. Is it important for you to be able to spend time with your children or your grandchildren? Is it important for you to be able to maintain good control of your diabetes and your heart failure. Let's understand what's important. Now, if that's important to you, we need to make sure that we try to keep you healthy, because we know that you ended up in the hospital last fall with, just as an example, a diabetic foot infection. That is not preventable by this vaccine, but this vaccine can reduce the likelihood of you having pneumonia, and pneumonia puts you in the hospital. So having those conversations focused on the patient's motivations can help you get there. But the harder somebody's beliefs are, the more likely you're to need to do more conversations. So keep working on it. I do this a lot with our residents in clinic. I do a lot with my own patients. You get there, but some take a lot more discussion than others. You've got to be consistent. You can't change messages or change focus over time.
Yes.
Because that's when you get in trouble. Is patients say, wait a minute, last time you said, okay, so that's again part of the reason it's important to document.
And Bob, can I also say, just to remind folks also that, we also have presumptions. And I love the fact what you say about assumptions too, right? And I think the idea that just because the patient says they don't want to get a vaccine today, we don't want to immediately assume that they're going to fall into this category of having a fixed belief either. I'm not saying that they're, but I think we want to keep, like you said, Bob, keep asking when they come back, because the reason they refuse the vaccine today could simply because they have a major tennis match they want to play in and they're worried about a sore arm, but they don't want to tell you that, right? I mean, so I think we want to make sure that we respect that side as well. Cancer question, Bob, I'm going to let you take that one.
Sure.
You're the clinician.
So Louisa asked the question, what about cancer patients undergoing chemotherapy? Is it safe to give vaccination? Well, in general, yes. If they're undergoing traditional chemotherapy, remember they're immune suppressed. That means they're at much higher risk for influenza, for COVID-19, for invasive pneumococcal disease, and for a number of other things. There is no evidence that cancer chemotherapy or traditional cancer chemotherapy or radiotherapy or surgery puts people at increased risk for those vaccines. Now, they may not get quite as robust a response, but remember, any protection is better than no protection. And if you don't give influenza vaccine to a cancer patient receiving chemotherapy, you are potentially putting them at higher risk of getting severe influenza and ending up in the hospital. Remember, neutropenia is very common with cancer chemotherapy, and that puts people at high risk for infections by viruses and bacteria. So now the caveat is some of the newer immune stimulatory drugs, there's a concern that some of those may cause increased reactogenicity with vaccines, or that may cause challenges. So I think it's important that if you're using some of those immune stimulatory drugs like nivolumab, that there be a conversation between the cancer provider and hopefully your local infectious disease doctor to talk through a risk benefit in those patients, what the best options are. And again, in the chemotherapy patients, we need to be very careful about live virus vaccines. There are not a lot of them we use now, but in those patients, MMR, yellow fever vaccine, or live attenuated, the nasal flu vaccine probably wouldn't be an idea during chemotherapy.
Bob, there's a question about healthcare workers. I'm going to tee that one up, and then, I think we can go back and talk a little bit about this. I think, the role of the healthcare worker in terms of vaccination acceptance cannot be underestimated. Because if you are going to be the number one consistent recommender, you also have to be able to answer the question, well, doc, did you get your vaccine? With a yes, right? And I think so it's important to keep that in mind as a role model, right? That's who you are. But the other thing I want to mention also is that, back in the right around the 2010s, the National Vaccine Advisory Committee actually did a report on healthcare worker influenza in vaccination. And I think one of the things that came out of the report is that, many times, many places with condition of employment recommendations, and I strongly support those, I think have them in place and just assume that that's what's going to happen. Condition of employment policies work best if there is a foundation of education that underlies those conditions of employment. So when a healthcare professional or healthcare personnel is coming into your institution, it is imperative to provide the education as to why you have that condition of employment policy. What are you trying to protect? Who are you trying to protect? Provide some basis of education about transmission and causality of that in terms of your patients. And I think then your condition of employment policy that lays on top of that becomes much better accepted. I think that's something to kind of fundamentally keep in mind as you go into that. Bob, some thoughts from you maybe?
I agree completely. And the person that asked the question also asked about religious exemptions.
Mhm.
Interestingly, there are not, to my knowledge, any of the major organized religions that have prohibitions against vaccines. There are many people that raise that as a concern, but I think the American Academy of Pediatrics has very nicely detailed a lot of that in some of their Bright Futures information. But I think helping people understand the why. I think about healthcare professionals as having triple risk when it comes to diseases like influenza, COVID-19, RSV. You can catch the disease from your patients. You can potentially take that disease home to your family. And if you're sick and you're not there, or you're ill enough, you should not be in the office. You are potentially putting your patients at risk because you're not treating them. You, the healthcare professional that knows them, and if you're not doing all the infection control things, you could potentially give them disease. So we really need to emphasize those aspects. And, there's been some pushback from some state legislatures against some of these healthcare provisions. I think that sets bad policy. But again, I can't control that. But I think we need to help educate and inform on multiple levels about the why for healthcare professional vaccination. And I think some of those same principles probably need to apply to school teachers, college professors, um, people that work in our jails, people that work in our nursing homes. All of those are areas that we have great opportunities to reduce the risk for staff and people that are living and working in those settings. If we help people understand the why, we're much less likely to have pushback. So Maria asks, weren't healthcare workers left off the eligible criteria for COVID vaccine under 65? Now, remember, those criteria are high risk criteria. Those are not criteria that say eligibility. COVID-19 vaccine is still recommended for adults. Okay, it's still recommended for all adults. And so it should be covered by health insurers, both public and private, at this point in time. And if it's not covered by an insurer for those adults, then they're potentially in violation of federal statute. So again, I encourage my healthcare professionals for COVID-19 vaccine, just like I do for influenza. The risks to you, the risk to your family, the risk to your patients. And on top of that, we probably need to be much more adroit at knowing what's going on in our communities, knowing what the CDC's respiratory viral data channel tells us about going on in our communities, and when it's time to start putting those masks back on.
Yeah, that's a good one. I think that's exactly right. And this idea of eligibility, I think is also important to remember that, with that the pediatric recommendation for COVID-19 has been listed now as a shared clinical decision-making recommendation. So it's still an official recommendation.
That's right. And remember, insurers have to pay for shared clinical decision vaccines as well.
Absolutely.
We haven't really talked about the off-label indication issue. As healthcare professionals, licensed healthcare professionals in the office, we often use medications off-label. We often use medications for pain that are not indicated, have been specifically approved for that type of pain. We can do the same thing with vaccines, but we have to recognize that if we give a vaccine that's not right under the ACIP recommendations, published recommendations, that insurer may not pay for it. And if we do that, we need to let the patient know what their cost implications be. Manish asks, what adverse reactions to prior immunization beyond anaphylaxis would you not recommend a repeat immunization? Well, anaphylaxis is by far the most common. Very rarely, I don't know that I've seen the numbers, but very rarely you can get a serum sickness type reaction to certain vaccines. That's going to be extremely uncommon. In patients that have significant immune thrombocytopenia after vaccine with bleeding, that would be a reason that you wouldn't want to give the vaccine. But again, those are very unusual situations and complications. The biggest challenge we bump into is people saying that they had a really high fever or really sore arm from shingles vaccine or COVID-19 vaccine. And the thing to remember is because that happened once doesn't mean it's going to happen next time. And because it happened once doesn't mean it's going to be more severe next time. So I would encourage continuing to vaccinate those patients and making sure they know that if you have those reactions, that it is recommended that you use acetaminophen or nonsteroidal anti-inflammatories as your health conditions allow. Use that right away when you start having symptoms to try to minimize those symptoms. I would just encourage everybody to keep your mind open, ask questions of your patients that have concerns, show them respect. Let's get people vaccinated and let's protect as many as we can in our society from vaccine preventable diseases. We're all in this together.
And I want to just say, you all are the number one reason why our patients get vaccinated. And you should have confidence in knowing that, and that vaccines are socially accepted. So you need to recommend, you should be pushing your recommendations with confidence. Thank you for everything you guys are doing.
Thank you, Dr. Hopkins and Dr. Tan, and thanks to you, our listeners, for joining us. As a reminder, to view the full program, which is called Turning Your Practice into a Vaccine Center of Excellence, click on the link in the show notes. And to get access to all of our new podcasts, you can subscribe to the CCO Infectious Disease Podcast, Apple Podcasts, Google Podcasts, or Spotify. Thank you, and we'll see you on the next podcast soon.